Hello, everybody. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. David Boyer, who's a senior partner with Retina Vitreous Medical Group in Los Angeles, also is an adjunct professor at the USC Roski Eye Institute, and really one of the authorities on retinal pharmacotherapy and clinical trials. Welcome back to Retina Synthesis, David.
Thank you very much, Carmen. It's a pleasure to be here.
Today, we're going to talk about an innovative therapy for diabetic retinopathy, so-called senolytic therapy. What do we mean by that?
Well, senolytic therapy involves the reduction in the cells that are senescent. Senescent cells are stress cells that no longer divide, and they accumulate in areas of disease activity. And the problem is they secrete discrete inflammatory markers. They have inflammatory factors, fibrotic factors, growth factors. This leads to a breakdown of the blood-retinal barrier and causes inflammation at the local site. So UBX 1325 reduces these senolytic cells. It actually gets rid of them, and it gets rid of them rather quickly. And what the end result is, there's remodeling of blood vessels at this point. The inflammatory cytokines that are present reduces, and you get vessel remodeling, and eventually the endothelial cells again become formed to the point that they don't leak. So it repairs basically the blood vessels, reducing leakage. And they've done some animal models where they've injected in the mouse oxygen-induced retinopathy model, and it does decrease neovascularization and decreases the avascular areas in this mouse model. So they took it to the clinic and to see if that would be able to be duplicated. And this study basically took patients with diabetes that were leaking. And in the beginning, they didn't want a very sick group of patients, but what they ended up with was a very sick group of patients. The study, and I'll go through basically the relative patients that were included. The theory behind the study was a little bit poor. What they had looked at is they looked if you gave aflibercept according to the label, that after the first 6 months, patients stabilized and basically only created or got one letter of improvement. And they felt that, introducing at this time the senolytic version 1325 against a sham, so that they could follow these patients to see what the problem was. So this was a 48-week study, and essentially patients were asked in the 6 months prior to being admitted to have at least 2 injections. And what they ended up with was actually 4.1 injections, or averaging almost an injection every 6 weeks in this group of patients. And they said, well, you have to have greater than 300 microns to have some macular edema. And what they really ended up with was almost 440 microns on average of edema, and the visual deficit was rather significant. So you had this run-in period, 24 weeks before, and then you administered a drop, and then you followed these patients. And they're basically relatively symmetrical groups. There was not a lot of difference. I think the sham group had a little bit of thicker retina, and the UBX 1325 had basically a little higher A1C. So the results were very interesting. After one injection, over 50% of the patients never required a rescue. They didn't they didn't need a rescue, whereas 80% of the sham patients required rescue before the 48-week period. The visions improved in the UBX group as compared to the sham, either looking at without rescue or even with rescue, though with rescue, the results became closer. There were certainly significant visual gains overall, with about 25% of the UBX patients gaining at least 10 letters, which was impressive. The CST worsened in the sham group, as one would expect, and improved slightly, but not to the degree that we had hoped. But basically, at the end of 48 weeks, there was almost a 20 micron difference. There was certainly a statistically significant difference between the two groups. And I think that, over 50% of the patients did not require a VEGF rescue in this group. Safety was good. In other words, you gave this drug, you didn't see any vaso-occlusive vasculitis, you didn't see any uveitis. So it did prove that one single dose of this UBX1325 to reduce some senescent cells could reduce the inflammatory component, reduce the blood-retinal barrier breakdown, and had a significant gain of vision over sham treatment over this 48-week period, with 50% of patients never qualifying for re-injection or rescue therapy. So it's interesting, and a drug that with one injection can do this. You certainly wonder if you need additional injections or if you need a run-in phase to stabilize, but it'd be nice to have some additional treatments that go this long in our armamentarium.
So OCT did not improve substantially?
There was a slight improvement in the OCT. Toward the end, it did improve a little bit more, close to 20 microns. I mean, the difference between the two groups was certainly statistically significant, but I would have expected to get this type of visual improvement. I would like to have seen some larger gains, but we're seeing this in other trials for other conditions, and even for diabetes, where you don't get as much CST change, OCT changes, as you do visual improvement. So, obviously we have to look at which patients improved and why did they improve, and go back to the OCTs and really see, did patients have drill that negated against the marked improvement? Did they have, cystic changes where they just end stage disease patients? I think, all that reevaluation is going on, but they plan on trying to go forward with a phase 3 trial.
So does the senolytic therapy downregulate VEGF?
No, indirectly it does. It reduces the inflammatory components that will stimulate, VEGF. It's not an anti-VEGF per se, so it's certainly, the mode of action is totally different. So you could actually utilize an anti-VEGF in conjunction with this to see, this is basically really going after the inflammatory component without a steroid. You don't get a pressure rise. There's no signs of any problems utilizing this. So, how this fits into, what we do on a daily basis is going to be, interesting. Maybe we have to treat earlier, and maybe the response will be better. Maybe this turns out to be a maintenance drug, or maybe it turns out to be a combination therapy that would be able to allow us to go much longer and get better visual results.
Is there any information on the design of the phase 3 clinical trial?
I don't think it's been totally worked out. As you know, from doing a lot of clinical trials and advising a lot of companies, when you do a phase 2, you want to gather as much information so you can go forward with the best phase 3 that you can. So these results are relatively new. I think the company is looking at which patients did better. Can we identify those patients, and can we include those? Do we have to limit the number of injections? Are there patients that, that basically were so thick that they were never going to really improve? So I think all that is being evaluated. And then once we have some additional information, I think that we can come together and do a clinical trial.
Well, David, thank you so much for this highlights of senolytic therapy. It sounds very promising, and a novel non-VEGF blockade approach.
Yeah, it really surprised me, to be honest. I mean, first of all, I had to learn what a senescent cell was before I even knew how to, what this was treating. But once I realized that these cells don't divide, and they liberate all these, factors that cause inflammation and cause vascular leakage, I was pretty impressed. It happens pretty quickly, and it's maintained for a long period of time before these cells build up again.
Great. Thanks so much.
Thank you very much, Carmen, for having me.